All right. So we should be going. Our ECHO sessions are an interactive learning community, so we do ask that you have your webcam and microphone on during our breakout groups, which will be an opportunity for discussion. And if you have any questions throughout the presentations or the case study, please put them in the chat and someone will answer your question there. And next thing, just a few housekeeping. If you would please rename your profile to your name and your organization if you would like. And you can do that by clicking on the 3 dots above your picture, and then you just click rename, type that in. All right, so I will now pass it over to my colleague who will be our facilitator today, Dr. Jennifer Hall-Landy. Dr. Hall-Landy leads our early intervention work at our institute. She is a psychologist and researcher with a specialty in early developmental delays. Dr. Hall-Landy is also faculty on our UMN LEND program and leads the ACT Early project. Her work is committed to increasing access and reducing health disparities. Welcome, Jen.
Thank you, Courtney, for that nice introduction. Can everyone hear me okay?
Yep.
All right. Looking for a thumbs up. Well, welcome everyone. We are so happy to have you here for our first Minnesota Project Scope session. We are very excited to have you here today. As Courtney said, we are a community of practice here today, and we are going to be talking about presenting, sharing expertise on neonatal abstinence syndrome, and we're also using that interchangeably with neonatal opioid withdrawal syndrome, or NOWS. We invited a large group of early intervention providers who support children and families. Welcome. Thank you for the work that you do. Everyone is welcome, even if you play a different role. And we also will be using the ECHO virtual training model, and I will explain that to the group. Next slide. Thank you, Courtney. So what is ECHO? We want to break down our acronyms today. What ECHO stands for is Extension for Community Health Outcomes. It's a model that we use to bring expertise, knowledge from healthcare settings, from universities out into the community. We say it is a way to democratize healthcare and knowledge. Knowledge should be shared. It shouldn't be contained, right? And that's what we're doing today. Just a really brief history on the ECHO model, because it's a pretty specific and interesting model. It started back in 2003. It started at the University of New Mexico with a doctor there that was a liver specialist. He ran into, and you may be wondering, why am I sharing about a liver specialist? Well, he had a situation we often see in healthcare. He had more people needing his care than he could provide. There was no absence of knowledge in his state. There was an absence of access to care. What he was seeing were people who had advanced stage liver cancer that if they'd come in earlier, they could have had treatment and perhaps their lives could have been saved. He said, I need to share this knowledge with general practitioners in the community to help spread knowledge, spread health, increase access. So we are doing an ECHO model. There are all types of ECHO models across the world. There's ECHO models on cancer, heart disease, diabetes, autism, and we are here today to tell you about neonatal abstinence syndrome, and we're excited to learn together. So a few key components: we promote health equity, we share our knowledge and expertise, we reduce disparities and increase access, we bridge healthcare and education, and we are a community of practice learning together. We believe knowledge shouldn't sit within the walls of a university, but should be made accessible and available to all. Next slide. ECHO models, such as Project SCOPE that we're doing today. And by the way, SCOPE stands for Supporting Children of the Opioid Epidemic. Want to make sure I am not using just acronyms here. But the 4 principles of our ECHO model we'll be using is 1, technology. ECHO models are virtual. And of course, we're in a pandemic, so of course this is virtual. But even outside of a pandemic, ECHO models are virtual. Number 2, we talk about best practices in healthcare and education and work to increase access and reduce disparity. We always will do a case study to apply our learning, which is, we think, one of the most exciting parts of an ECHO model. And then step 4, we do an evaluation. We collect data. We give you an opportunity to give us feedback about what you learned, what you liked, and what we can do better. Next slide, please. So this is the first of 8 sessions. Today, we're going to cast our net broad, wide. It's an introduction to the opioid crisis in Minnesota. We're also going to be talking about social and political determinants of health. And as you can see, we have up to 8 sessions. Each one specializes and gets a little more focused, but we're so happy to have you here with us today. Next slide. Our agenda will be brisk. We'll move through it because we want to have time for everything and our case study. We'll also try and post the agenda in the chat. One of our goals is we start on time and we end on time. So to be respectful of your time. Next slide. So I have the pleasure of introducing our speaker today. Liz Corey is from, and I'm sorry, I have 2 screens here, the Minnesota Department of Health, where she leads evaluation efforts for the CDC's Overdose Data to Action grant. Liz completed her Master's of Public Health with a minor in epidemiology from the University of Minnesota. Yay, Gophers, good job. We approve. She focused her studies on maternal mental health and adverse childhood experiences. Her background includes conducting vaccine preventable disease surveillance and providing care to pregnant and parenting women experiencing mental illness and substance abuse. Welcome, Liz. We are very excited to have you here today.
Thank you. Thank you. So as Jennifer mentioned, I'm with the Minnesota Department of Health. I'm an evaluator with the Injury and Violence Prevention section, primarily working on overdose prevention, but I do work across our section specifically related to neonatal abstinence syndrome. I'm also a co-chair of the Minnesota Perinatal Organization's initiative focused on improving outcomes for women and children impacted by opioid use disorder, which is how I was connected with this group. Next slide, please. So at the end of our time together today, I hope that you all will have an increased understanding of the history of the opioid crisis, a primer on the social determinants of health and substance use, and a general sense of the landscape of opioid use disorder and opioid overdose in Minnesota. Next slide, please. Perfect, thank you. So before we dive in, I want to take a few minutes to frame the conversation. Substance use disorder, including opioid use disorder, is a preventable and treatable chronic condition, just like diabetes and asthma. Substance use disorder does not occur in a vacuum and can impact anyone at any time. I want to go through a couple my slides were backwards, sorry. So to start off with talking about stigma and language, the negative associations and feelings towards people who use drugs is stigma, and that can lead to social isolation and barriers in accessing healthcare. The stigma increases vulnerability for drug overdose and other drug use related health harms and decreases access to pathways to recovery services. The language we talk about when we talk about substance use and people suffering or experiencing substance use disorder really matters. We can each play a role in decreasing substance or stigma surrounding substance use by using person-first language. The phrase person first simply means acknowledging the humanity of an individual before defining them based on the health conditions they experience. So some examples of first person language are on this slide here to incorporate into your vocabulary. And these are a person who uses drugs, person who injects drugs, person in recovery, and person living with opioid use disorder. A word that is incredibly stigmatizing and really common in our language is drug user or addict, and those are examples of non-person first language. It's also important to note that the language relating to substance use and misuse is changing quickly, and the list of terms on this slide does not cover everything. When you're working with people in communities impacted by substance use, it's a best practice to ask directly what language they prefer to use and follow their lead when discussing substance use and treatment. I want to define some of the key terms we'll be using. Opioids are a class of drugs that includes both illicit drugs and prescription medications. Opioids are often prescribed after surgery or injury or to relieve cancer pain. Common types of prescription opioids include oxycodone, brand name OxyContin, hydrocodone, which is Vicodin, morphine, fentanyl, and methadone. Common types of illicit opioids are heroin and illicitly manufactured drugs that replicate the effects of prescription opioids, like oxycodone and fentanyl. Opioid misuse is the use of any opioid for a purpose not consistent with legal or medical guidelines. So that would be using an opioid any way outside of how it's been prescribed to you. Opioid use disorder and substance use disorder are formal diagnoses. Opioid use disorder is a specific diagnostic criteria if you are using primarily opioids as your substance of dependence, but you can have opioid use disorder and substance use disorder as well. And the umbrella diagnostic term for dependence on any substance is substance use disorder. So while death is the most profound impact, there are many other harms associated with drug use that we visualized here with this injury pyramid. Death from overdose has become the most visible part of this pyramid, but death from overdose results not from a singular time of using substances, rather is representative of a substance use pattern, frequently rooted in pain, trauma, and suffering, either of the individual, their family, their community, their culture. Again, substance use does not occur in a vacuum. No one wakes up and decides to start struggling with substance use or engage in risky substance use. To provide some context to this injury pyramid, for every one opioid-involved death, there are 2 opioid-related hospital admissions, 4 opioid-related emergency room visits, 7 opioid-related EMS runs, and 30 opioid-related treatment admissions. This is really representative of death as just being the tip of this pyramid. So again, for every 1 death, there are at least 30 treatment admissions. So when we think about who is impacted by the opioid epidemic, what we're actually thinking about is everyone who has experienced pain, trauma, or suffering, or may experience pain, trauma, and suffering. A substance use disorder can occur at any time throughout the lifespan. Often the rhetoric is that it's impacting adolescents and younger people, but there are many people of all ages who are impacted by substance use who start struggling with substance later in life. So everyone who knows, works with, or loves these people who have experienced pain, trauma, or suffering, or who may, which is frankly everyone, could be impacted by the opioid epidemic in some way, either directly or indirectly. The question then becomes, what creates the demand for altering substances in the first place? Below that diagnosable condition is pain, trauma, and suffering, whether that's physical pain, emotional, psychological, intergenerational, all of the above, and more. Next slide, thank you. So while opioids have been getting a lot of airtime in the media and policy attention in the last 2 decades or so, opioids have been widely used in the United States for over a century. I'm going to go through a very brief history of opioid use and regulation in the United States, the opioid crisis of the last 2 decades, and how racialized policies have impacted and influenced the opioid epidemic. I want to say again, this is going to be very brief, and I'm happy to connect outside of this echo and provide more resources. A colleague of mine in the prevention team teaches a course at the University of Minnesota Public Health Institute just on the history of opioids. If anyone's interested in that, I'm happy to provide some more information later on as well. So at the beginning of the 1900s, there was widespread heroin use across the United States. I'm sure we all have seen the pictures that now seem so crazy that people were just giving away heroin cough syrup at your doctor. It was very common to be able to just buy opioids in your corner store. There was no federal regulation to address the increasing rates of heroin addiction either. Doctors and pharmacists were free to prescribe heroin and other opioids at their own discretion. The federal government then steps in with legislation requiring federal regulations, starting with the Pure Food and Drug Act in 1906. This act allowed the federal government to regulate medication prescribing. This was followed by the Harrison Narcotic Act, which was passed in 1914. This act taxed doctors and pharmacists for prescribing opioids. So regulation, not criminalization at this point in time. The first federal legislations that criminalized heroin passed in 1920 and continued to become increasingly criminalized through new bills through the 1960s, including the landmark 1951 passage of federally mandatory minimum sentences for possession and sale of heroin. So in that span of 50 years, it went from being able to be prescribed by any doctor or pharmacist to having a federal minimum sentence. So in the grand scheme of things, pretty short from no regulation of criminalization to really quite strict criminalization. So in 1971, US President Richard Nixon publicly declared a national war on drugs, and the establishment of the Federal Drug Enforcement Agency quickly followed in 1973. This change in legislation ramped up US efforts in spending to enforce drug law, increased prosecution of both drug sales and possession. The war on drugs is widely accepted now as a racialized policy that disproportionately charged and incarcerated people of color who used or bought and sold substances, resulting in the disproportionate incarceration rates that we see today. In 1986, the Reagan administration built on war on drug policy and increased punitive law enforcement efforts focused on people who use drugs, establishing zero tolerance laws for illicit drug possession. In more recent history, federal funds under the Obama, Trump, and Biden administrations have been dedicated to a mixture of prevention efforts, including law enforcement engagement, expansion in treatment services, and overdose emergency funds in the form of naloxone distribution. I should mention, I should have had this in my key terms. Naloxone is synonymous with Narcan, which is a drug that can be used to reverse an opioid overdose at times. On this slide, I want to show an image of these three waves of the rise in opioid overdose deaths. I just want to preface right away that we just went through that opioids have been in this country since at least the early 1900s. So this graph is really of waves is how they've been currently defined, or what we know is the opioid crisis. But now we know that opioids have been an issue in this country for a lot longer than just the late 90s, early 2000s. So from 1999 to 2019, nearly 500,000 people died from an overdose involving any opioid, so including both prescriptions and illicit opioids in that category. The rise in opioid overdose deaths can be outlined in those three distinct waves. Notice that's the rise in the deaths, not that they haven't been occurring. I do just want to keep reiterating that these opioid overdose deaths were occurring long before the 90s. So the first wave began with the increased prescribing of opioids in the 1990s. Some of you might have heard about and followed the case with Purdue Pharma and the families involved in creating these opiates and how they were encouraging their salespeople to advertise these as non-addictive. So that's really what's kicked off this first wave. So it's been increasing since at least 1993, but we started to see a drastic increase in the late 90s. So the second wave began in 2010 with rapid increases in overdose deaths involving heroin. And the third wave began in 2013 with significant increases in overdose deaths involving synthetic opioids, particularly those involving illicitly manufactured fentanyl or fentanyl analogs. The market for illicitly manufactured fentanyl continues to change, and it can be found in combination with heroin, counterfeit pills, and cocaine. These three waves, this image is from the CDC and is national, but the Minnesota trends do mirror this. We're currently experiencing a third wave with a significant increase in fentanyl overdoses. These lines here say any opioid, other synthetic, heroin, and commonly prescribed. But I do want to note that for many overdose deaths, there are more than one type of opioid involved. And so that's that. Any opioid line is the total. But it's important to know here that heroin counts could be the same as the other synthetic opioids here if someone was using both kinds of substances at the time of their death. Of course, word on the street is that we've been in a pandemic for a year. We talk about it all of the time. It's important to know that it has really impacted the opioid crisis too. We often use the term opioid epidemic. So we've been dealing with dueling epidemics with the opioid epidemic and then the COVID pandemic. We've seen impacts of COVID on the opioid crisis in the form of increased deaths nationwide, substantially increased. I'll go through some data later on my presentation specific to Minnesota. We've been hearing from the organizations that MPH funds and people who receive services in those organizations that there's been an increase in isolation and reduced access to treatment. Many folks who are used drugs or who are in abstinence from substance use would go to group meetings or go to work, go to church, go to places to recreate, and they're not able to do that. And that can be really difficult for people at any point in their substance use journey when they're seeking to find social connection and social support. So I want to touch briefly on the opioid crisis and structural racism. Again, this is really high level. I wish I could give hours and hours to this topic, but just a primer. So until the early 2000s, the US popular media primarily associated use of illicit drugs with communities of color, dating back at least a century when the use of opium and opium dens were mainly presented as occurring in Chinese immigrant communities only. Media has long portrayed people who use drugs as ethnic minorities and people more likely to commit violent crimes, be violent in general, and live in urban areas. The crack epidemic of the 80s and 90s was portrayed as impacting communities of color only. There's been a substantial pooling of resources into opioid prevention and treatment through state and federal government sources, and a noticeable shift in our culture that opioid addiction is something to be treated and viewed compassionately, something that people kind of fall into by accident versus taking an active role in substance use, which is how folks who experienced discrimination in the crack epidemic were viewed. They were viewed as substance users who didn't have a choice in their addiction and were always destined to become that way. Whereas now we've really seen a change in that. This different perspective and approach to treatment rather than punishment and incarceration has surprised and frankly deeply saddened communities of color who did not receive that same level of funding and attention that white communities and users are receiving presently. Admittedly, there's still a long way to go in providing treatment that's equitable and destigmatized for all people who use drugs, but there has been far less funding put into improving treatment access and especially access to culturally specific treatment among communities of color. And there's a substantial disparity in access in general through disparities in health insurance coverage. So heroin and opioid use is not new among communities of color, yet many stories of successful recovery highlight white people from rural areas who found themselves addicted to opiates following a prescription legally obtained from a medical provider. Opiate use was resulting in deaths among communities of color prior to what is now known as the first wave of that opioid epidemic in the late 90s. But the waves of the opioid crisis themselves are centered on increases in use among white people. The surveillance of opioids has really ramped up recently. This grant that I'm working on was just awarded to MDH within the last 2 years. So we have surveillance on the opioid crisis really from the last couple decades. So we're not capturing the people of color who are being impacted by the opioid crisis prior to that recognition of the crisis. The lives that were lost to opioid overdose prior to the identified first wave mattered and still do matter, regardless of more attention being paid to this type of substance use once it spread to communities that have not previously and historically been portrayed as experiencing addiction. And I would encourage you all, when you think of the opioid crisis, to hold a picture in your mind of who you've seen the media represent as being impacted by the opioid crisis. I'd be willing to bet that it is these stories from rural white America, older people who perhaps fell into this but obtained that substance legally first, when in fact that really is the result of media portrayals of who is being impacted. So as you go back out into the world, when you hear stories of opiate addiction, just ask yourself if it seems equitable to you. If you are seeing people of color, if you are seeing poorer people or people living in urban areas being represented as much as you are other demographics. I'm going to switch gears a little bit here and give another brief introduction to the social determinants of health. Some of you might already know about this and it might be a little bit of a repeat, but I want to draw some connections between social determinants of health and substance use. So health starts where people live, learn, work, and play. Conditions of life are connected to healthy outcomes, especially when it comes to the treatment of chronic pain, mental health, and trauma. Social determinants of health are the conditions within a home, family, school, and community that can impact a person's ability to be healthy. Social determinants of health include the physical characteristics of a neighborhood a person lives in, access to healthy food, safe housing, quality education, economic well-being, and many others. The social determinants of health, which I've acronymed here as SDOH, can be grouped into 5 domains: education, access, and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. I want to say off the bat too, this is how the CDC has grouped 5 domains of the social determinants of health. As you do more reading on this subject, you might find that they're grouped into different ways. That's kind of just a personal preference in some ways, if people like to have larger groups or bigger groups that they categorize these into. Some additional examples of social determinants of health that impact a person's health and well-being and quality of life include safe housing, transportation, racism, discrimination and violence, job opportunities and income, physical activity opportunities, polluted air and water, language and literacy skills. These are all wrapped into these different domains of social determinants of health. They also really contribute to disparities and inequities. For example, people who don't have access to grocery stores with healthy food are less likely to have good nutrition. That raises their risk of lifelong health conditions like heart disease, diabetes, and potentially obesity, and even lowers life expectancy relative to people who do have access to healthy foods. An important social determinant of health that influences all of the factors I just listed is adverse childhood experiences, or ACEs, which I'm sure many of you on this call have experience with, so we'll just do a brief intro of those as well. So ACEs are significant social determinants of health that have been linked to an increased risk of mental health issues and substance use. ACEs are grouped into 3 categories shown here: abuse, neglect, and household dysfunction. Abuse includes physical, emotional, and sexual abuse. Neglect includes physical and emotional. And household dysfunction includes living with someone with mental illness, having an incarcerated relative, witnessing your mother being treated violently, living with someone who experiences or has experienced substance use, and then divorce between your parents. ACEs are incredibly common both nationwide and in Minnesota, with an estimated 40% of Minnesota students experiencing at least one ACE. And again, to experience an ACE, it's anytime under 18 years of age. And of course, if these happen to anyone at any point throughout their life, they run the risk of experiencing trauma and pain from these, but ACEs are just limited to age 18 and under, at least in the way that we study it. Of course, not in practice. There is a dose response with ACEs. So the more one has, the greater risk of negative health outcomes. There's also an association between the number of ACEs one has and their race. So in Minnesota, students of color are more likely to have multiple ACEs compared to white students. And the higher likelihood of ACEs among students of color is closely connected to social determinants of health and institutionalized racism. For example, students of color in Minnesota are disproportionately likely to have an incarcerated relative, which we can link back to disproportionate incarceration and criminalization of substance use. When we think back to the injury pyramid I wanted to show to frame this conversation, we can place ACEs in the base of the pyramid as pain, trauma, and suffering. But when we link it all together, social determinants of health, ACEs, and substance use, a pyramid isn't necessarily the best way that we can conceptualize this. I like to use a social ecological model, which is what you're looking at on the screen here. Social ecological models are used to better understand the multiple different levels at which a person's health is impacted and how they influence one another. This model considers the complex interplay between individual, interpersonal, community, and societal factors. providers. Essentially, a social ecological model details some determinants of health and how they influence and overlap with one another and show up in a person's life. This social ecological model shows some of the potential determinants of health that may influence substance use, including a sense of personal safety, safe housing, supportive parents, a safe neighborhood to live in, and affordable health insurance. In the next slide, we're going to trace through how a societal level factor could influence an individual's health. But we'll start at the societal level on the far right, which includes governments, institutions, and systemic racism. At this level, we might have legislation that supports fringe service programs, medically assisted treatment or MAT, providers and services, and expansion of behavioral health services. Legislation can only be created at the societal level by a government with authority over the geographic area. Next, we'll move to the community level. At this level, we can trace how legislation that supports MAT providers and services could increase access to MAT in a community as more providers or clinics could be licensed and able to offer this service. At the interpersonal level, the acceptance of MAT can influence how the service is viewed and utilized by a social group. So the interpersonal level includes friends, families, coworkers, neighbors, etc., all of whom can have an impact on a person's health-seeking behavior. Lastly, at the individual level, the availability and acceptance of withdrawal symptom management using MAT can impact a person's likelihood of maintaining abstinence from substances. Without changes in legislation, greater access to MAT in the community, and acceptance by a person's social circle, this person might not have been able or willing to access MAT for withdrawal symptom management at all. Stigma towards people who use drugs can occur at all of these levels, including at the individual level through self-stigma and shame. Hence why it's so important that substance use prevention work includes stigma reduction components at every level. I'm going to run us through some slides with some information on opioid use in Minnesota. I see Rebecca put a comment in here that she'll send out a copy of the slides post-presentation as a PDF. Feel free to send out the notes for the presentation as well. I've included the source documents for these graphs and those notes. You all can access those if you're interested. Alrighty, this first slide, we're looking at non-fatal overdose here. And what I want to draw attention to is the trend of increasing over time. You'll see these little dips in 2018 with non-fatal overdose. But for the most part, we've seen a pretty solid upward trend. Just going through 2016 here, but this trend has continued since the early 2000s. And we see an increase here in heroin and other opioids excluding heroin. Overdose deaths are increasing as well. Preliminary statewide data show that drug overdose deaths increased 27% from 2019 to 2020, or from 792 to 1,008 deaths. Compared to 2019, drug overdose deaths increased in March, peaked in May, and with a second peak in August of 2020. March 2020, when the impacts of the pandemic began, including Minnesota's first stay-at-home order, saw the largest monthly increase, or 64%, from 53 to 87 deaths compared to the months in 2019. The trend of each individual monthly drug overdose total being higher than the previous year continued throughout all of 2020 and has continued into 2021 as well. All of Minnesota saw an increase in overdose deaths. It's not just limited to the metro area. So preliminary data show increases in drug overdose deaths in both the 7-county metro and greater Minnesota, which is all of the other 80 counties in our state. In the metro, drug overdose deaths increased 40% from 2019 to 2020, growing from 483 to 673 deaths. And in greater Minnesota, drug overdose deaths increased 21% from 2019 to 2020, from 276 to 335 deaths. It's important to note here that I'm providing counts. So it looks like the metro has a lot more deaths, which it certainly does, but the metro also has a much larger population. These 7 counties are where most people live in our state. So when we think about the impact of overdose deaths in terms of the proportion of communities that are being impacted, it's highly likely that if we were to do the math, the rate for greater Minnesota would be higher. And we would see in the metro and greater Minnesota that there would be similar trends with the rates being higher among communities of color, which leads me to the next slide, that the state rate masks significant drug overdose disparities. African American and Indigenous populations are dying from drug overdose deaths in Minnesota at unequal and increased rates compared to white people. In Minnesota, African American and Indigenous people both die at much higher rates. African American 2 times more likely to die of a drug overdose than white Minnesotans, and Indigenous people living in Minnesota are 7 times more likely to die of a drug overdose than white Minnesotans. These differences in overdose rates among these communities of color are due to systemic oppression, historical racism, present-day racism, and inequitable access to the resources that people need to live a healthy life. So inequitable access to many of those things I listed as social determinants of health being influenced by historical and current policy. The race rate disparities in drug overdose, could you go back a slide actually? Thank you. So the race rate disparities in drug overdose deaths mirror other racial disparities in Minnesota, like those seen in graduation rates, infant mortality, poverty, incarceration, removal from the home, unemployment, home ownership, and suicide. Minnesota is often listed as one of the best states in the country to live in for many of these indicators, but there are huge gaps between white people living in Minnesota and people of color. And these differences are impacting people's lifespans and the rate of early death and the rate of poverty. So they are all interconnected and all very important when we're thinking about how we can help people be healthy. So in Minnesota, factors like systemic racism have prevented communities of color from having those equal access to resources. Intergenerational trauma, intergenerational substance use, and ACEs are all social determinants of health heavily influenced by systemic racism. The health disparities and inequities experienced by communities of color can be directly tied back to these disparities in overdose rate. So differences in overdose rates here are not due to individual behavior differences. They are due to systemic influences, social determinants of health. Of course, we think about person first language, and these numbers all represent people with very full lives, but we need to recognize that white people who experience substance use might be less likely to experience a death because they have increased access to treatment and other forms of care. Right, now I'm ready for the next one, thank you. So the mortality rate disparity between Indigenous and white people continued and worsened in 2019. So from 2010 to 2019, the Indigenous mortality rate almost tripled from 29 per 100,000 to 80.7 per 100,000, which is an 178% increase in the rate. Well, the African American mortality rate increased from 11.7 per 100,000 to 20.2 per 100,000, or 73% increase, and was almost 2 times as high as the white mortality rate. We have some preliminary data that we have not published yet, but that shows that people of color experienced a drastically, I don't want to use significant, that's an epidemiologist term, but a drastic increase in overdose deaths following the murder of George Floyd, representative of how the things that are happening in our communities and in our built environments and in our societies influence individual behavior. I want to wrap up with some key messages for you all. So as you leave this session, next slide, please. Please remember that substance use is preventable and influenced by many factors outside of an individual's control. Substance use can be treated, and compassion and active destigmatization of substance use are crucial to improving the health of all Minnesotans. The opioid crisis has roots in racialized policies that do not treat everyone equitably. As public health professionals and early childhood professionals, people involved with any other people, if you're in any healthy field, you've got to consider how we can actively address inequity in the opioid crisis response. Social determinants of health and racism impact all aspects of health, and disparities in social determinants of health are directly linked to increased risk of substance use, overdose, and barriers to accessing treatment. That's all I have in terms of content for you all today. I know we've got some time for questions, and I'm happy to connect one-on-one or connect folks to other members of the prevention team at MDH for further discussion. I'll put my email in the chat right now.
Thank you so much, Liz. That was a wonderful presentation, a wonderful broad overview. I really appreciate how you talked about social determinants of health and ACEs, as well as talking about the disparities. So I so appreciate it. And additionally, too, the history was quite interesting. I did not know the history on opioid use in the US. We are happy, and we actually are ahead of schedule. Yay, thank you, Liz, to answer any questions. If anyone has any questions for Liz, you're welcome to put them in the chat. We'll just take a look. And Liz, you said people are welcome to contact you. We will be sending your slides out as well, if that's okay.
Yeah, awesome. And while I'm on here waiting for questions, I just put my email in the chat, and I'm going to put in some links to some of our MDH opioids pages too, so folks can visit those if they are so inclined to do so.
Wonderful, wonderful. And not to put you on the spot, but while we're waiting for questions, Liz, as you probably heard at the beginning, we have a lot of early intervention providers on here who work with children and families, young children. Anything that would be helpful for them to consider in their work that you see in your everyday work? I mean, if you could give, and I know I'm putting you on the spot, but any piece of advice.
Yeah, absolutely. So before I was in my current role, so it'll be less of in my current position, but for several years I worked in social work, supporting pregnant and parenting young women, many of whom had substance use disorder. And then while I was going to graduate school, I was able to work with the family home visiting program. And I think the one tip that I learned from both my personal and professional experience working with folks who are experiencing substance use is that you have to hold good intention. They don't want to be harming themselves. They don't want to be harming their children in any way. I think humanizing the people that have experienced substance use or who are currently experiencing substance use, and recognizing the humanity in that everyone wants to be loved and cared for and safe, and to provide love, care, and safety to their children was really impactful for me in my personal work. I think learning more about a person's history to help to understand perhaps how they got to where they are, and also help identify what makes them really resilient and what their strengths are. And you can work on those with a family unit and really play to their strengths.
Absolutely, Liz. Absolutely. We say all families love their children and want the best for them. And I like your suggestion, humanize, learn, seek to understand. I'm going to just check to see if we have any questions. And again, Liz is going to put in some additional links around data. I'm assuming, Liz, this is data on opioid trends in Minnesota.
Yeah, so that first link is just to our MDH opioids homepage. It's kind of the landing page. And then the second link I put in is our opioid dashboard, which does have data on opioid indicators in Minnesota.
Wonderful. A wealth of resources and information. I can't wait to look back at the slides. Thank you so much. And again, feel free to, are you staying on, Liz, with us? People can
yes, I am.
private message you or email if you have any questions. We really appreciate that. Was very, very helpful. And I learned a lot. Thank you so much.
Yeah, thanks so much for having me. Looking forward to connecting with anyone who's interested.
Yes, and you are welcome anytime to come to any of our sessions. And again, this is our broad overview session, sort of our introduction. We will be narrowing it down more specific as we go through the sessions, but this is the beginning. Thank you for starting us off so well. I am now going to switch, as I said about the ECHO model. One of the key components of ECHO models is we learn together, We have a didactic session, as we just heard, and then we bring it to an applied level with a case study. So right now I'm going to introduce my colleague, Dr. Jessica Simasek. Jessica is the director of the ICI Tele-Outreach Center on the University of Minnesota campus, as well as an expert in early intervention. And Jessica is going to guide us through our case study portion of our project scope session. Jessica, are you there?
I'm here. Can everybody hear me okay and see me?
Thank you. Yes, thank you, Dr. Simasek. I appreciate it, and I'm going to turn it over to you.
Great. Well, thank you. I'm so happy to be here today. And this will be our first case study that we're walking through. And I see that Rebecca has put this agenda in the chat again, which is really helpful. Just that reminder is we're going to walk through some background information on this case, this child, and this family and the situation that they're in. And then you're going to have the opportunity to ask some clarifying questions, which hopefully I'll have some answers to, but I may not, but I'll try my best. And once you have that information, you're going to go into breakout rooms. This is really, again, about applying things that we're learning, and then also, gathering information from the community, and everybody on this call has expertise that we want to leverage as well. When you're in those breakout rooms, and I appreciate that we have a little bit of a time buffer just in case we run into any snags there, but you'll have the opportunity to respond to 3 questions. And they're kind of leading questions. So if your conversation goes in another direction, that's okay. But while you're in those groups, we ask that you kind of take some notes on what you're talking about so you can come back and share them out with the full group when we're done. So with that, I'm happy to be here. Like Dr. Hall-Landy said, my background is early intervention, special education, and supporting children with behavioral needs. And this particular case has some of those things going on. So we're going to talk about it. We like to lead with strengths as well. And so we're going to really try to highlight strengths of this child and this family. And we encourage you to do that when you're in your breakout rooms too. This is a 25-month-old child, and she lives with her grandparents who are her legal guardians, and they live in greater Minnesota. So they live in a little bit of a more rural area in Minnesota. And some of the things that are going to come up as we talk about this case is there is a history with some potential trauma experiences. There's a history of drug exposure prenatally, and then there's also some child development concerns, and those are related to how this child engages with some sensory things in the environment, and also some potential self-regulation and behavioral challenges that are coming up for this child and this family, and tied to that, some of those social determinants of health, and particularly this family living in a location where it's difficult to access services. We want you to keep that in mind as well. Next slide, please. This is a little bit more background about this case. So this child's been living with their grandparents since they were 10 months old. They don't have a lot of details about her life up until then, but their niece, her biological mother, was reported to have a substance use disorder and had used methadone and marijuana during pregnancy, and the child had tested positive for those at birth, although there were no reported significant withdrawal symptoms. While the mother worked on her recovery, she asked for the child to live with her grandparents, who have since agreed to take permanent custody or be her permanent guardians. And they've also accepted the child, this young girl's young brother, who's 12 months old. So now both children are living with them permanently. Their mother is incarcerated, their biological mother is incarcerated, but wants to be as involved as possible. Next slide, please. So these are some of the areas where we're going to try to highlight some strengths that have come through with this case that we want to make sure we're leveraging where we think of recommendations. So in a developmental assessment, there was motor, communication, and cognitive domain areas were all testing in the average range. Social, emotional, and adaptive areas were a bit below average. The evaluators reported that the child was very friendly and very easily engaged in the evaluation process. So it was really a joy to connect with. Her grandparents are very loving. They seem very loving and supportive caregivers to these children. And they've been really good advocates reaching out to try to access services to support this child as well. And they live on a farm about an hour from the Twin Cities so may experience some service access difficulties. All right, we can go to the next slide. Some of the primary concerns that the family would like some support with is the child can be aggressive at times towards her 12-month-old brother and towards the family dogs. She's been observed putting a blanket over her brother's face and pressing down in a way that, of course, would be dangerous, and also, pulling hair and pinching her infant brother. And it's also been observed that she'll at times kick and hit the family dog or roughly pull on its fur. There's also, as I noted before, some issues with sensory stimulation in the environment. So she dislikes having her hair wet, which makes it very difficult to do bathing. Or if she gets wet, she might want to take her, that clothing and change it right away. And that she also does a lot of seeking of kind of tactile input. So it might be touching a lot of things in the environment, which can be challenging in community locations, et cetera. And the area that their most pressing concern at the time that they want support with is when she's left alone, she may engage in frequent fecal smearing. So not that she's left alone frequently, but this might happen if she's in her crib and everyone's asleep and she wakes up, and it's at times occurred in other settings as well. Okay, next slide. So some of the common, potential stressors or triggers that have been reported around these concerns would be if she's not getting her way. So maybe if she's being told no, or that she has to wait for something to happen, or maybe they can't go do something at that time that she'd like to do. If her caregiver's attention is divided or diverted for some reason. So if they might need to be attending to her infant brother or doing some other things around the home, it's sometimes when some of these things might occur. Also, her communication, she isn't always, she's 25 months old, she's not always understood, and her articulation is a little bit of an issue. And so if she's trying to communicate something and it's not being understood, that can also be pretty frustrating. And those previously noted issues with sensory stimuli. So some of the things that have been tried, she has not successfully accessed services yet, but she has been evaluated for Help Me Grow. At the time, she was told she didn't qualify. And she also had a recent evaluation through the Developmental and Behavioral Pediatrics Division. And so that's the only assessment to date, and we're currently working on recommendations for this family. All right, and so the goal from this case study is to provide some strategies and interventions to address these concerns and address the whole family's quality of life. Next slide, please. Okay, so I'm going to get us ready to go into breakout rooms. These are the 3 questions we're going to consider. So we're going to go ahead and read those, and I'll give you a second to think about that. And if you have any clarifying questions, I'm going to invite you to ask those in the chat, and we'll try our best to get those answered before your breakout rooms. We won't do any recommendations yet, so these are just if you want a little bit more details, we can try to provide you with those. And then you'll go ahead and bring those recommendations to your breakout room to share with your group, and then to come back and share with all of us so we can all learn from each other. So we want to understand how social determinants of health might inform the situation. So what are some challenges and potential solutions that we can incorporate into our recommendations? As we already identified, the caregivers would like support related to the fecal smearing behavior and also the aggression towards the sibling that's occurring, just out of course, safety considerations. So do you have strategies or supports that you'd recommend for the caregivers to try on their own or to connect with in their community? And then our third point is these are very loving grandparents, they're retirees, but they've also got 2 pretty young kids at home. And so if we could provide any recommendations for community supports or self-care ideas, just to keep, and also keeping in mind that, they're not gonna be able to travel super far to do those things, but to make sure they're doing some self-care to take care of themselves so they can be bringing their best to take care of these kids. All right, so I'll open the floor up for any clarifying questions you would have about either the breakout groups that we're about to go into or about the case itself. I'll keep an eye on the chat here. Thanks for putting those questions in too, Rebecca. Okay. Just making sure.
Yeah, thanks, Dr. Simasek. We're not seeing any questions on our end.
Okay, and I just got one just privately, and this is actually a very great question. I think we're still doing pretty well on time. So we had about 10 minutes set aside for the breakout rooms. So we'll probably take about 10 minutes. If you haven't done breakout rooms yet, we're all pretty advanced in our Zoom learning probably this year. But what will happen is Courtney will open them and you'll get an invitation to join the room, which you can click on, and that will bring you to the room once it opens. If you have any problems in there or want to come back to the main room for any reason, you can also leave the room early. There'll be a button you can press. If not, you're going to be talking with your group, and then you'll get a 1-minute warning when the room is going to close and we're calling you back to the main room. If you are on the phone or experiencing some other kind of difficulty with joining the breakout room, we're going to have this main room also kind of serve as a breakout room too. So don't worry, you can still participate in the activity. All right. Okay, so we're going to give these breakout rooms a try.
And Dr. Simasek.
All right. Well, we seem to have slowed now, but a lot of us came back, which is great. We know it's the time of day where you might have other things starting to go on. So thanks for coming back. And we hope that you had some really great conversations. So this is our opportunity to open up the floor to the groups to share out, if you have 3 or at least, maybe your top few recommendations for this family and this child. Because we're doing fairly okay on time, you're welcome to unmute yourself and say those recommendations. If you're more comfortable doing so in the chat, you can do that, and then I can share them on your behalf. And then we're going to attempt to summarize them into our kind of top 3. I see them already coming in the chat now. So everyone, thank you for getting them in there right away. And please feel free, if you would like to come off mute, to tell us any of them too. All right, well, I'm going to start you. Everyone's doing a great job getting these in here right away. And let's see, do we have like 5 rooms, Courtney? About 5 or 6 rooms maybe?
6.
6. Okay, so it looks like we already have 3 rooms either reported back or in the process of reporting back. So even if you don't have a full 3, if the other rooms have at least a top, recommendation or even just discussion point from your discussion, please feel free to throw it in so we can summarize it. Okay, so from one of the groups, I will go ahead and share on your behalf. Their top recommendation or kind of note for us to consider is to that question about that healthcare access or kind of the quality of the services that they're able to access from where they are. They're in a rural location. They have some limited access, that they may have social, community, and neighborhood resources, or that there may not have a kind of peer group or social support as caregivers, if I'm interpreting that right, and feel free to correct me if I'm not. And so maybe some linkage with, again, if I'm kind of extending your first recommendation here, some potential linkage with some kind of peer or like caregiver to caregiver support group, or support net of some kind would be a recommendation. I think that's a great one, and many of those are available virtually or remotely, not requiring a lot of travel. Some of the recommendations around the fecal smearing and some of the aggression would be having like pajamas, like the zipper pajamas, and putting them on backwards for those times when she's going to be kind of on her own, bedtime, when you're not going to expect them to sit awake and watch her all night. And then having maybe a doll to take care of around the aggression towards a sibling, or just kind of helping her learn, she's 25 months old, helping her learn to be gentle with a baby. And then you maybe had, that's, I think, okay to share, you had more questions than answers, right? And I think many of us in this situation would be gathering more data too, in different forms of data to try to support a family going through this. So that's great. And then some potential, again, like community resources and providers would be things like Head Start, Early childhood family ed, we know is a very Minnesota program that really benefits a lot of families, and it's across the state. And that's a great place could kind of, again, do some of this modeling and just learning with other kids, but then also some support for the family. And they could meet other families with kids around the same age. Early learning scholarships, help for school or childcare, church or community support groups. So thank you. Those are really robust and great. And now we're going to kind of keep going down, and I'll try to keep summarizing as we see themes pop up across these recommendations. Giving some advice to the grandparents that they might want to go back to help me grow to elicit some support. So maybe things have changed since the last time they contacted Help Me Grow, and maybe the needs are a little bit more significant now than they were then, or at least, you know, they could get connected with other types of services. I think that's a great recommendation. It sounds like these grandparents are very eager to advocate, but some skill teaching or recommendations to them around how to advocate, what to be asking for, might be helpful. A Part C evaluation again. So this is where we're starting to come up with some themes here. So we don't know how long ago that evaluation occurred. And this is an age group that of course is rapidly changing in development. So it's important that if they are continuing to have concerns, or those concerns are worsening, that they know that that's not a one-time evaluation opportunity, that they can continue to go back. So I think that we're starting to we've had 2 groups now come through with that as a potential recommendation. So I do think we're kind of starting to think that might be one of our recommendations. Again, please feel free to edit me if that's not where anyone is heading. All right, so let's go on to another group here. So doing some family assessment information gathering, again, knowing what other communities might be available, or is there some childcare access that they could get access to, a pediatrician that maybe specializes more in this area, access to some kind of play therapy, a functional behavior assessment. So the state, you know, looking at some of the different services that are offered of having someone come in and help do a functional behavior assessment. To understand why that might be occurring, and what ways could target that in a more kind of individualized manner. Strategies and ideas for encouraging adult-child attachments or more social emotional development. Those are great. Okay. And there's a lot. I have like 17 messages, so I'll try to go a little more quickly, and please feel free to keep me on time this is thrilling that we had so many people putting, at first we're like, oh, we hope someone's going to put in at least one. So this is great.
Yeah, wonderful.
Yeah, and Courtney is going to help us save the chat. So all of your time here will not be lost. But I'm going to go through and again, just try to kind of highlight where we're seeing maybe something new or something that's kind of a reoccurring theme that can become one of our kind of summary recommendations. I think we've decided one recommendation already is likely in the realm of maybe let's try to reassess or reseek some of those assessment services, especially in case that happened a lot earlier or something has changed. All right, so again, this is some resources for things like podcasts and supporting child development. I think those are great, right? These are grandparents who were parents at one point, but now they kind of have young children again and probably want access to the latest and greatest recommendations. Considering those social determinants of health, so considering if there are, well, not if, likely they've already reported there are these access issues, what are some things that we could do around access issues? So some things have already been, suggested, which is things like ECFE, which should be available throughout the state. Hopefully isn't too far of a drive for the family. I'd like the idea of some of those virtual kinds of social connections or peer connections. Let's see. A lot of community and social opportunities are coming up as a limitation for this family. And then I think we're all kind of trying to rack our brains as to what would be some solutions there. And I think others have said, are they interested in church? Are there other maybe systems that they're not involved in yet, like childcare systems where either they can meet other families, they can get a little bit of respite time, the children can get access to some other kids and structured, environments. Okay. We have 20 new messages and I'm not even through this top few, so I'm going to do my best here. But please, if you have something burning that you really want to make sure we hear, feel free to come off of mute and share that. If not, I'm just going to kind of scroll through these.
Oh, you have, Dr. Simasek, you have a wealth of resources and comments here. If anyone wants to come off mute and say something that they really want the group to hear, otherwise we will compile sort of the top ones and we will send them out to everyone. And so thank you so much for all of these wonderful recommendations. Dr. Simasek, do you have any closing words for the case study?
Well, I think so. Just if I had to at least get us to a few here, and I apologize that I'm not doing everybody's share out justice, but a few of the themes I've seen come up as I've been kind of going down through the rest of the list are, again, re-eval, reassessment, opportunities for community connection. So ECFE came up a bunch, and other community supports like church or other places that they can go to their community to get some access to just peers and support. And then there's also a bunch of great recommendations around things that the grandparents can access around just child development or supports for themselves and respite and things like that. So I think those would be kind of the general categories of where our recommendations are probably headed. So thank you so much. So it was just thrilling to get this wealth of information. So thank you again.
Wonderful. Thank you. We're seeing firsthand the bidirectional in terms of sharing knowledge and expertise, that we bring a didactic presenter here, and then we hear back, we do an applied case, and we just get a wealth of resources and suggestions that we all share together as a community of learning. I couldn't have asked for that to be better. So thank you so much, everyone, for your suggestions. We will send that out. Additionally, I have a few final housekeeping tips, and then we will let you out the door. Next slide, please, Courtney. Our last step in the ECHO model. So we were virtual. Our first step, we shared best practices. We had our case study, which you did a beautiful job with. And step 4 is collecting data and evaluation data. So after this, you will receive an email to complete a brief REDCap survey about this session. We do offer certificates of participation for you, but you have to complete the evaluation survey. So please complete that, and you will get that when the series is done. So watch your email for that. Perhaps check your spam folders if you don't see it in the next day or two. But we would love feedback from all of you. And again, next slide. Thank you so much for attending our first session today. We look forward to seeing most, if not all of you. I know our sessions fills quickly. I hope you got a chance to register. We will be offering it again, hopefully. But next week, Tuesday, May 25th, we'll have Dr. Heather Bell, who works with addiction and treatment with mothers. Is she an OBGYN, Courtney? We'll have throughout our series, we're going to have a couple OBGYNs come, some neonatologists. We're going to have a wealth. We're going to have parents, community members, and really look at neonatal abstinence syndrome from multiple lenses. But next week is Dr. Heather Bell. Courtney, were you about to share?
I do not think she's an OBGYN. I believe
Okay.
more general practitioner.
She may be a general practitioner that works
with a
moms.
focus in addiction.
Okay. All right. Yes. So it will be very good. We will focus on mothers and the family next week. I hope all of you can make it. And additionally, we want to get everyone's names. Thank you for putting those in the chat. If you joined by phone, thank you. Feel free to stay after and give us your name and your role. Correct, Courtney? You want to collect that as well to give you credit for being here.
Yes.
And finally, next slide. Is that my last slide, Courtney?
Just our sponsors.
Our sponsors today for this Minnesota Project Scope Echo Session, Minnesota LEN, which is the Leadership, Education, and Neurodevelopmental Disabilities. It's a mouthful fellowship program, which we'd invite all of you to apply for. Our Project Scope partners, Institute on Community Integration, the Telehealth Outreach Center, which Dr. Simasek leads, and the Minnesota Act Early Project. Thank you to our Project Scope team and all of our sponsors. And thank you to all of you. We appreciate you being here and sharing your time and your knowledge. And we are done 4 minutes early, so you get 4 minutes back. Have a wonderful evening, and we'll see you next week. Bye-bye. Good night, everyone.
Is there anybody on the phone who would like to share their name and email with us?
I had to come. I'm Susan Williams from St. Paul. I had to come super late because I was facilitating a reflective practice group. So you're compiling them? Do you just want me to put it in the chat?
Sure, Susan, welcome. I'm glad you came. We certainly understand back-to-back meetings. Yeah, we just, part of the ECHO model is everyone chats in and your name and your role, and then we use that as attendance because we do offer certificates of participation. So we just want to have a record that you were here. Welcome. I'm glad you made it.
Email address, is that what you, okay.
Yeah, Courtney, what all did you need?
I'm putting it in.
I have her name and St. Paul Public Schools, and I also have a whole list. Yep, that's perfect. Just email. Yep, perfect.
Perfect. Exactly what we need. And if anyone has stayed on from the phone, Rebecca, are you seeing someone from the phone?
I just want to vouch for Susan that she was in my group.
I saw her join.
That's very helpful. So that's all.
Oh, Rebecca, thank you. And thank you for facilitating and doing that job. And then, you know, she asked for volunteers to speak and the room went crickets, which happened to me in all my small groups at the conference that I was a part of as well. So I know exactly how that feels.
Yes.
I just felt like I'm coming in so late. I don't really, I'm just playing catch up. So
yeah. No,
okay, and we'll send it out.
I do not see anybody on the phone that remained, but I think most of them in the chat did put in their information, even if they were calling in, but I can't guarantee that.
Okay.
It's okay. All right.
thank you all.
Thank you, Susan. Hope to see you next week.
Yep.
All right,
Bye-bye.
Thanks, everybody.
Yes.
Okay, I'm gonna stop recording.
All right, just